Hello, I am delighted to welcome you all to this session on a subject that forms a crucial foundation in the field of dentistry, the acrylic partial dentures. I am Dr.N.Gopi Chander, and I am excited to guide you to the intricacies of this vital aspect of prosthodontics with a special focus on preclinical perceptions. As preclinical students, you are at the threshold of a journey that combines theoretical knowledge with hands-on skills. Acrylic partial dentures plays a pivotal role in the restorative dentistry, offering both functional and aesthetic solutions for patients. The next minutes, we will dwell into the essentials of acrylic partial dentures, providing you with a solid understanding and actionable insights that will set the stage for the future clinical endeavors. We are going to break down the essentials of acrylic partial dentures with a special focus on what our preclinical students need to know. Let's get started. The acrylic partial dentures or the provisional dentures given to the patients until a definitive prosthesis is constructed. It restores both aesthetics and function for an interim period, and it's been widely used, especially in our Indian scenarios. It's commonly called as either as gum strippers, temporary partial dentures, or TPD. As stated earlier, it is indicated for an interim period, but however, in many situations, it has been used as a long-term prosthesis. It is indicated in partial tooth losses. It can be in terms of a single tooth loss with multiple teeth missing in a dental arch. It's the most cost-effective solutions compared to any treatment modalities of prosthesis. Can be compared to a fixed dental prosthesis, either in terms of a tooth-supported or in terms of an implant-supported prosthesis. Also, it's suitable for the patients because it falls within the budget constraints, especially in the developing countries and the poor countries. It has significant advantages and disadvantages. It is less expensive compared to other prosthetic options, very simple to construct. It can be customizable to the patient situations and can be used in all situations, so versatile in terms of offering a prosthesis that can suit all situations of an edentulous arch or a partial edentulous arch. It's comparatively non-invasive, and being a removal prosthesis, it's easy to clean and maintain. It also has its limitations, so a thorough understanding on the science of removal processes, especially the acrylic partial denture, is essential. It damages the gingiva adjacent to the edentulous area because it doesn't have a component called as rest, which is seen in more definitive processes. Since it damages the gingiva, and if it's not been regularly maintained and cleaned, it can lead to sequelae of periodontal diseases. And the material by which it's made up of is acrylic, so it has its inherent limitations of dimensional changes and poor mechanical properties over a period of time, especially in the long-term usage. The main purpose of providing acrylic prosthesis is to replace the missing teeth for an interim period so that it restores the oral function and aesthetics. And by that situations, it can help in terms of improving the quality of life for patients. It starts with making a definitive impression. It has got its clinical procedures as well as the laboratory procedures. The clinical procedure starts with the selection of impression tray to impression making and subsequent clinical procedures that follow in terms of jaw relation, trial, and denture insertion, and elaborative laboratory procedures, which is of my area of concern in terms of discussing this topic to a preclinical student. So before making the impressions, it's ideal to know the selection of impression. Trays are commonly selected with the use, impressions are commonly made with your stock impressions trays. The stock impression tray comes in 5 different sizes, starting from U0 to U4 and L0 to L4. U denotes the upper or the maxillary tray, and L denotes the mandible or lower impression tray. These stock trays are readily available trays in the market and can be used at ease on a patient. The other impression trays are custom trays, which are normally not used in the making the impressions of your dentureless patient, especially for your partial dentures. It's more used in terms of complete denture patients or in terms of the implant processes situations. The selection of tray is randomly done. Ideally, there's a scientific way of selecting the tray. Use a divider, measure the intercanine distance and intermolar distance, and see the same space has been available in the stock trays. Accordingly, the tray has been selected. The tray extension should be adequately checked. It should cover all the areas of the teeth, and there should be adequate space present between the inner border of your impression tray and the outer surface of the teeth. If there is no adequate space present, then it's difficult to make the impressions, and there can be a lot of perforations or pressure points in making the impression, during making the impressions. So see that the tray is extended adequately and there's a satisfactory space present between the teeth and the inner border of your impression tray. When checking for the extension, the peripherals of the tray should extend till the sulcus of the tray or 2 or 3 millimeters short of the sulcus of the tray. And the posterior part of the tray should extend till the tuberosity in the maxilla and the retromolar pad in the mandible. If the trays are not extending properly, can be adapted with use of the modeling wax. If the impression material of choice is going to be alginate. If it's going to be silicones, then it has to be extended with acrylic. Normally, when making the impression for your partially dental situations, especially for acrylic partial dentures, alginate impression material is being used, so it can be extended adequately with the modeling wax. Most important criteria at a preclinical situation is to know how to support the tray while making the impressions. See that the forefinger and the middle finger is going to be supporting the body of the tray, and the thumb is located at the handle of the tray. Guide the tray in an angulation inside the patient mouth, so it's easy for you to take this tray in terms of the support into the patient oral cavity. If it is less supported, then there are greater chances of inadequate application of pressure in the while making the impression, as well as in terms of the movement of the tray that happens, especially in the mandibular impression tray. So tray has to be adequately supported. It's also mandatory that this process has to be learned at the preclinical stage, so that the practice and on practice and as a habit, it makes a person easy to make the impression during the clinical procedures. It's also vital to know the position of the operator in terms of the patient. When making the mandibular impression, the operator should be at the front of the patient, that is at the 7 o'clock positions. When making the maxillary impression, the operator should be at the back of the patient, that is at the 11 o'clock positions. This is in terms of the convenience forms and also in terms of the ergonomics that will help in terms of making the impressions. Once the tray is selected and once the basic ergonomics is understood, the impression is made with your suitable impression material. For acrylic partial denture, as stated earlier, it is made with alginate impression materials. It's a elastic impression material which can get into the undercuts and help in terms of easy fabrication of the cast as well as the making of the processes. It records accurate details. The dimensional stability is the only limitation for the alginate impression material. So the cast has to be made at the earliest within the maximum of 8 to 9 minutes. Technically, the cast of the should be made with the alginate impression material. Once the cast is obtained, see that the adequate base has been done over the cast. That gives one in terms of the strength for the cast. Also, it also gives in terms of the presentation format of the cast. See that the eventual situation is whatever that is being recorded from the patient is adequately duplicated. If it's going to be a preclinical cast, see that the situations are adequately made. Most of the preclinical casts require some more clearances that is being made from the rubber mold, require greater clearances compared to the spaces that is being present. See that at least the cervical end of the adjacent natural teeth, the height of the edentulous ridge has been trimmed according to the cervical height of the adjacent teeth. On the base of the cast, 3 orientation grooves are placed as shown in the figure over here. These are not retention tools. These are the orientation tools, each in terms of orienting the cast to the articulators. During de-articulation of the cast, you want to re-articulate the cast. These reorientation tools plays a greater role in terms of putting the cast back to the articulator. And being in edentulous situations, the base of the cast has to be angulated, as shown in the figure. It has an angulation at the canine and the molar region, and the base, the flatter part of the cast, which is going to be parallel to the last tooth seen of the cast. In terms of the mandibular cast, the anterior should be more rounded. It may not have an angulation in the central incisor region or the midline region, which is seen in the maxillary cast. Once the cast is made, the provisional denture base is being made. Here I happen to show you two clinical situations or three clinical situations, which is of a Kennedy's class 3 and Kennedy's class 1 in the mandibular cast. Shellac is the most ideal denture-based material, provisional denture-based material by which the acrylic dentures are made. Situations might arise where you can use a self-cured acrylic denture basis or a light-cured acrylic denture basis, but it may not be required going to the advanced level of provisional denture basis. The most simplest form is going to be the shellac denture basis. Being a thermoplastic material, it's easy at the preclinical level to adapt and change the situations in terms of the extending or reducing this extension of the denture basis according to the needs. By rule of thumb, it's see that the denture bases are adequately extended. Wherever the edentulous area is present, it has to be extended till the sulcus. In the areas where the teeth are present, it should be slightly above the gingival margins, and it also has to extend to the posteriormost margin of the teeth. For example, in maxilla, it should extend to the last molar of the tooth. And in mandible, if it's going to be denture situation, it's going to extend to the retromolar pad. And if it's going to be the maxilla, if there's going to be a denture situation, it has to extend to the tuberosity region. Once the denture bases, acrylic provisional denture bases are being made for the acrylic dentures, occlusal rims are being made. The occlusal rims are going to be in accordance with the conventional dimensions. See that the height of the occlusal rim is going to be on the height of the adjacent teeth. The width can vary between 4 to 6 in the anterior, 6 to 8 in the premolar region, and 8 to 1 centimeter in the posterior region. Following this, a maxillomandibular relationship record has been made. It is taken to the patient mouth, and the maxillomandibular relationship is recorded. Alter the occlusal limbs will alter to the requirements of the vertical dimension as well as in terms of the horizontal relationship. That happens in clinical situations. In preclinical situations, the casts are hand articulated first. See that the imprints of the opposing teeth are seen on the occlusal surface or the occlusal rims, so that it helps in terms of positioning your cast with the articulator. The cast is oriented, both maxillary and mandibular casts are oriented to the articulator. The conventional principles of articulation of using a 3-point articulator in terms of the orientations are followed. Tie an elastic band or a thread connecting the incisal pin and the two condylar pins, and accordingly orient your cast. The occlusal plane of your cast has to be oriented to the elastic band. See that suitable supporting wax supports have been placed below the cast so that it doesn't move and has some kind of stability while articulating the cast. Once the cast is articulated, the teeth are arranged. The conventional teeth arrangement principles are followed. Whichever teeth are missing, those teeth are replaced according to the clinical situations or according to the preclinical situation that is required. The principles of teeth arrangement principles are followed. But some situations where the occlusal surfaces may not completely interdigitate with the opposing natural teeth, in that situations, a selective grinding can be done on the occlusal surface of the tooth. But as a rule of thumb, the conventional teeth arrangement principles are followed. And in case of situations where there's going to be interferences, that area alone has to be trimmed, or selective grinding of the teeth has to be done to obtain the appropriate maximum intercuspation. See that the teeth are in the maximum intercuspations on the articulator, so that's easy for you to do a trial dentures as well as check in terms of various aspects of the denture comfort during the trying of the dentures. Once the teeth arrangement are done, the most commonly skipped procedure in the making of the clasp. In case of the acrylic partial dentures, you have a rod clasp, whereas in terms of cast partial dentures, you have a cast clasp that has been casted in the metals. The rod clasps are made from the ready-made wires, orthodontic wires, usually of 21 gauge. See that, and a C-shaped clasp is commonly made for your acrylic partial dentures. The C is adapted over the adjacent natural teeth. See that adaptation follows the contours of the teeth, or else it can lead to a damaging forces on the tooth. Once the adaptation is being made, the C adaptation is made, the crossover is being made with a better adaptation, and a loop is being made at the terminal end of the clasp. This acrylic loop plays a greater role in terms of retaining this clasp with the to the dentures. If the acrylic loop is not made, then the denture clasp will not be retained in the denture. And for the adaptation of the clasp to the provisional denture basis, the adequate space has been created in the provisional denture basis. If it's going to be shellac base plate, find the area where the clasp is seen so that the space is created and this space is being blocked with the wax. There are greater chances that your denture bases shellac denture bases can break. There's going to be greater amount of spaces created for the between the clasp and the denture bases, or greater number of clasps is being made. So adequately see that protection is being made in terms of creating the space, and it's also been sealed with the wax immediately once the space has been created. Once the clasp is made, and in case of clinical situation, the denture has been tried and checked for all the comfort and aesthetics. On satisfactory evaluations, the dentures have been de-articulated from the cast, then it has been waxed up. If it's going to be an acrylic denture basis, if it's going to be a provisional denture basis with shellac base plates, ideally you don't require a wax up on the palatal surface and the lingual surfaces of the mandibular denture basis. But if you feel the thickness is going to be lesser, it should be at least minimum of 2 millimeter thickness. If that thickness is not going to be there, then adequate wax up of your palatal surfaces of your maxillary denture and the lingual surfaces of the mandibular denture has to be waxed up. Or else, conventional wax up around the teeth is done to improve the aesthetic value of the denture in terms of giving the wax, carving the gingival margins as well as in terms of the marginal and digestive. So wax up of acrylic denture is done following a satisfactory trial denture basis, trying of your partial dentures, and the further processing of your laboratory stages of the denture happens. The procedure of flasking done over here is the reverse flasking, unlike your conventional complete denture, which we do a normal flasking. Here, the lid and the body of the flask has been sealed, and the cast has been invested in these two components of the flask. Whereas in the conventional flasking, the base of the flask is being used where the cast is invested to the base of the flask, whereas in the reverse flasking, it is going to be invested on the opposite side of the flask, that is the body of the flask and the lid of the flask. Before placing the cast, see that the adequate space exists between the cast and the inner surfaces of the flask. Then invert the clasp with the dental stone. There are variations in thought of using the dental stone and the gypsums. Both has its strengths and limitations. Dental stone provides, especially for your removed partial dentures, provides more adequate strength, whereas the plaster gives you more porous spaces, helps in terms of easy for your deep flasking procedures. So invert the flask with the dental stone. See that all the parts of the cast is covered except the areas which has been covered with waxes. De-waxing is done in a regular de-waxing bath. Scrub out all the waxes that has been attached to the mold areas as well as in the cast. It's packed, processed, and cured. The denture is obtained by de-flasking procedures. It has been finished and polished in according to the conventional protocol using the different grades of sandpapers and trimmers. Ideal to use the acrylic stones first to finish it. See that all the rougher margins have been removed, all the plaster margins have been removed with your plaster gypsum particle that is stuck on the denture has been removed with your wax lasers and plaster knives. Then a stone, various finishing stones are used in terms of trimming and finishing the denture bases. And final stage, it has been sandpaper with 3 grades of sandpapers. Commonly used finishing grades of sandpaper are 120, 100, and 80. It starts with 80, go to 100, and then to 120 in dry sandpapering. Then the last used sandpaper grade, that is 120, is used also for your wet sandpapering in terms of finishing the dentures. On wet sandpapering, it is polished with a pumice for greater lustre and finishing of the dentures. The finished denture is inserted to the patient, evaluated for the comfort and aesthetics. Ensure that proper fit and comfort is obtained with the dentures. The most important in the clinical situations is going to be the educating the patients on the care and maintenance. Commonly made mistake is patients will insert and remove the dentures from the class with the help of the class. As we educated the patient has to push the denture bases from the sulcus area rather than using the clasp. It's also necessary that the patients have to be educated in terms of the maintenance of the dentures, especially in terms of not wearing the dentures during the night. And when it has been removed from the mouth, it has to be stored in a humid environment, in a container of water, and has to be adequately brushed with your regular denture maintenance cleaners so that the properties of the materials are going to be adequately maintained. The patient care and maintenance plays a very critical aspect in terms of your acrylic partial dentures. Daily cleaning is mandatory. Use of denture cleaners. If not, at least your regular toothbrush and the toothpaste that has been regularly used can be used for at least, that's the minimal requirement for maintenance of the dentures. And the most important aspect of your acrylic partial dentures is the regular maintenance. That is the assessment of the fit and function of the dentures and making adjustments if necessary in situations. The acrylic partial denture has a lot of variations compared to your cast partial dentures. It's a provisional dentures. It's not a definitive processes, but people have been using for a long-term provisional process. It restores all the aesthetics and function that is required. And dentures uses rod clasp, which is going to be the major limitation because the rod clasp doesn't have an occlusal rest, whereas the rest is seen in the definitive processes that will prevent the denture to sink into the edentulous areas, or rest offers a support for the acrylic definitive cast partial dentures, which has been missing. Since there is no supporting component for the clasp assembly, the denture can move towards the tissue areas and can strip the marginal gingiva. That's the reason why it's called as gum strippers. The cast partial dentures or a definitive process which has got a metal framework and has got all the components that can help in terms of supporting the process, retaining the process, and also improving the stability of the process. Especially the rest and the cast class play a greater role for the use of cast partial dentures as a definitive process. So it's mandatory that people understand the differences between the definitive processes and a acrylic partial denture, which is used for your temporary purposes. So the carry-on thoughts are quite going to be simple. People should understand what is an acrylic partial denture. The tray selection is going to be mandatory in terms of fabricating the process, especially in terms of inadequate knowledge of tray selection can be disastrous in terms of the impression making. The material of choice for your impression making for acrylic partial dentures, the finishing of the cast, especially in terms of the base of the cast, the angulations, essential angulation that has to be made at the base of the cast, and the reorientation grooves. The type of denture bases to use. Ideally, it is for acrylic partial denture at the preclinical level, it is essential to use a shellac denture basis. If it's going to be more definite, if the situation warrants, the clinical situation can be replaced with your acrylic, self-cure acrylic denture basis, or in terms of light-cure denture basis. Fabrication of the occlusity should have an understanding in terms of the orientation of the cast, and especially in terms of the articulating the cast with the articulator and the signs of articulators. So there should be some understanding in terms of making the processes. Teeth arrangement, making of the clasp, waxing procedures, the processing and finishing of the dentures, And the differences which is essential to be known between the acrylic partial denture, which is used for interim processes, and a cast partial denture, which is a more a permanent solution. And the references from where the data can be obtained for acrylic partial dentures. These are the references that I happen to use it. It's from McGregor Removal Partial Dentures, Stewart Clinical Removal Partial Prosthodontics, and textbook of Preclinical Prosthodontics. These references more discusses about the cast partial dentures. There are a few chapters that discusses in terms of acrylic partial dentures. It's mandatory for a clinical student to understand the differences between the cast partial denture and acrylic partial denture, and also understand the science of fabricating your acrylic partial dentures. Thank you.